Let me say it's a real pleasure to be here and to be present for the opening of this new Global Health Research Centre. Really is very nice to be here. What do I need? This one, I think. I've got this title of Investing in Global Health Research, and it seemed to me that, much like Melanie, really the thing to do is to start by reflecting on this unequal world that we're in. And again, moving from looking at a map of the world which is based on land area and resizing it according to various conditions. I'm going to take a slightly different spin on it to Melanie and really focus on poverty, at least to start with. And this is resizing the world according to numbers of people who are living on less than $1 a day. And again, you see that it is Africa and India in particular that really become bloated there, Southeast Asia to some extent. Looking at that, though, there is an important complexity that is coming along that we really do have to pay attention to. And that is that nowadays, something like 70% of the world's poor people don't live in low-income countries, they live in middle-income countries. And what this is pointing to is that increasingly what we're having to grapple with is inequity within countries, and that adds another layer to the work that we need to do in global health. Health and wealth are inextricably linked. The top graph there shows childhood diarrhea as just one measure of illness around the world. And again, we see that Africa and India are where most of the cases are happening. And at the bottom, wealth. I chose number of doctors to show where they are. And where are they? Well, they sure as hell aren't where all the cases of diarrhea are. You could look at that another way. This is a graph that comes from the World Development Report in 2006. And this plots countries according to life expectancy on the y-axis and wealth as in gross domestic product along the x-axis, and a regression line showing that as you become a wealthier country, your life expectancy increases. We're interested particularly on those countries at the left-hand end of that graph there, where they are not wealthy, they're poor countries, and for small increases in their wealth, you can get a disproportionate increase in their life expectancy or in health. And there are outliers from the graph there, and mostly the countries that are above the lines are countries which are fairly equal. There's not a great deal of inequity of wealth within them. They have policies that promote support for the poor, progressive policies, and also that they are looking to have health systems that have wide access for their populations. So again, you can improve the health by just using the resources that you have better. Now, with that inequity, where does Africa, the poorest continent in the world, actually sit? Well, with 1.1 billion people, it's home to about 15% of the world's population, but it suffers from a quarter of the disease burden in the world and only has 3% of the health workers and 1% of the economic resources to be able to deal with that. And if we look at particular populations, let's look at children and women. For children, there has been substantial improvement. Child deaths have roughly halved over the last 22 years around the world. That has not been even. The numbers of stillbirths and of neonates in particular have remained stubbornly high, and they now represent large proportions of the deaths that we see within children. There's great inequality around the world. The child mortality rate in sub-Saharan Africa is over 100, whereas in the UK it's about 5. So a 20-fold difference in mortality rates among children. For mothers, also there has been substantial progress. We've seen again roughly a halving of mortality rates over the last 20 years. But still we're in a situation where there are few deliveries happening in hospital. Women, if they're lucky, might be attended by a trained birth attendant. There's something like 300,000 maternal deaths each year, and the vast, vast majority of those are avoidable and preventable. Again, we see a lot of inequality. The maternal mortality ratio in sub-Saharan Africa is around 500 compared to 12 per 100,000 births in the UK, a factor of 44. And just to personalise this a bit, let me just ask you about the lifetime risk of a maternal death. Madam, what would you think that the risk is in the UK of a woman dying from a maternal cause over the course of her lifetime? 1 in what would you imagine that might be? 1 in? 1 in 20,000, okay, thank you. And Madam, could I ask you for sub-Saharan Africa, what do you think, a woman living in sub-Saharan Africa, what do you think the chance of her dying a maternal death might be? Higher, lower? 1 in...
Less. I'm not...
1 in...
1 in...
1 in 100. Okay, they're pretty good guesses. Let me tell you what they are. For the UK, the chance of a woman dying of her lifetime of a maternal death is 1 in 4,600. For sub-Saharan Africa, it's 1 in 30. So what is the Wellcome Trust doing about global health and the issues that we're describing there? So the Wellcome Trust has actually been engaged and involved in tropical medical research since before its inception, actually. Henry Wellcome himself, our founder, set up floating laboratories on the River Nile to treat the populations of Sudan and Uganda. And today we support thousands of researchers in dozens of different countries. And our annual spend on international activities is over £100 million. And I'm pleased to be able to say that in our strategic plan, we are committing to continuing to be involved in global health research. Our strategy really has 3 main streams. One is to support science that's going to improve health. One, that we want to broaden the research base where scientific endeavour can be conducted. And thirdly, we want to support international networks and partnerships that are focused on the problems of resource-poor areas. And within our scientific focus, really there are 2 main areas. One is around infectious diseases, and the other is around population or public health research, which might be on communicable or non-communicable diseases. The reasons for those are really reflected in what one sees in the global burden of disease and the report that came out in 2010, where of 53 million deaths around the world, about a quarter are due to communicable diseases, 2/3 to non-communicable diseases, and the rest to injuries. If you look just down at sub-Saharan Africa, there that bucks the trend. 3/4 of the deaths there are due to communicable diseases. So they make up the majority in that part of the world. And this needs to be set in the context that over the last 40 years there have been substantial increases in life expectancy of more than 10 years for men and for women. But there is an increasing importance of non-communicable diseases. This is just looking at the proportion of of deaths from communicable up here, non-communicable in dark blue, and injuries down here for low income, lower middle, upper middle and high income. You can see as countries get richer, there are few communicable diseases and more non-communicable diseases. The sorts of places where we're interested in working in the low income and lower middle income, actually now there's about equal numbers of the two. And what that means is that we are facing an unfinished agenda with communicable diseases and at the same time a rising tide of non-communicable diseases occurring. We have various funding mechanisms. Many of you will know about these, that we can support fellowships to provide personal support for researchers at different levels of their research careers. We've introduced investigator awards for those who have tenured posts already. We have strategic awards for flagship projects and collaborations, and we've introduced over the last few years a number of specific schemes for global health on clinical trials, health in humanitarian crises, health systems research, and human heredity and health. And all of these are things that we're doing in partnership with other funders, and most of them we're doing in partnership with DFID, who are one of our favoured partners for doing these kind of studies. So again, this is us supporting partnerships on problems of developing countries. So talking of flagship projects, one of those is around our major overseas programs. We have 5 of these around the world, and these are centres of excellence where there is a critical mass for conducting research in the countries where the problems really are. And 3 of these at least would have figured on Melanie's map of where her network can start to interdigitate with work that is already going on. So we have 5 of those. And we also have fellowship program for public health and tropical medicine applicants, and that's been going really since 2006. And in the 6 years that's been going on, we've made something like 109 awards. You see at a large number of institutions in a large number of different countries. And most of those have gone to sub-Saharan Africa, with roughly equal amounts going to the Americas and into Asia. But if you sit back and look at that, there's remarkably few centres of excellence given how large the countries which are of low and middle income status actually are. And those fellowships that we've provided, 109 in 6 years, that's good, but perhaps we could do better there, and they do seem to be scattered all sorts of places. Now, what can we do to actually accelerate excellence in these places? Well, there are really 2 things we do. One is that we've been working hard on supporting the building of capacity for conducting research, and these are a number of awards that we have made for individual training programs at existing centres of excellence. We've also provided awards to actually strengthen institutions, particularly universities in Africa, so they are better able to actually support research and good researchers. And we have also provided awards at national level to provide systems and competitive funding for research within those countries for national researchers in those countries. The other thing that we've done is that we have relaunched our Centres for Global Health Research. These, as Melanie said, were established last year, and they've replaced our Centres for Research in Clinical Tropical Medicine, which had been running for about 20 years. We've aimed here to actually expand their remit so that they will support clinicians but also non-clinicians from the UK, but also from low and middle income countries into a career in global health research. We want them to be a focus for expertise and resources, to be bases where top quality research and training can be conducted, to help people to have a structured career progression in a field which tends not to have had anything of the sort in the past, and to provide a home institutional base, particularly for those who are coming from the UK and going overseas. So we awarded 5 of these. One of them has gone to this centre, the Brighton Sussex Centre, headed by Melanie Newport. And I have to say, I think this is a real achievement. For a medical school that has only been in existence for 10 years, to be up in competition like this and to get one of these awards is a really fantastic achievement. So really well done on that. So finally, I just want to look to the future. You all know about the Millennium Development Goals. By 2015, we will have reached the end of the period of the Millennium Development Goals. So far, I'd say there's been patchy progress, not that much in Africa really. And while there have been 3 that have been particularly related to health, in the debate that is going on around what happens post-2015, where people are talking about sustainable development goals, it's really not clear what the profile for health is going to be among those. But some ideas and support are coalescing around a recent report that came from the Lancet Commission on Investing in Health. And the point that this makes is we really need to make the economic argument for investing in health. And these are the 4 key points that they make there, and I'm just really going to focus on the first 2. So this is the point that there is an enormous payoff to be made from investing in health. If we increased annual health expenditure by $5 per person in high burden countries, we could prevent vast numbers of child and women deaths within a generation. This would represent a 2% overall increase in expenditure, and it would prevent more than half of all child deaths and maternal deaths. In economic terms, the investment yield would be somewhere between 9-fold and 20-fold the value in socio-economic benefit. And that would be reflected in higher GDP, higher labour productivity, and more savings. And these are the kind of arguments that ministers of economics want to hear, and people in Congress and prime ministers. They want to hear the economic argument. Whereas we may be actually more interested in the idea that we are, perhaps for the first time in our history, at a time when we could eliminate health inequalities between nations within a generation. We've got the financial capacity, and we've really got the technical capacity to do this and to have low-level mortality everywhere in a generation. Of course, we might have the technical capacity to do much of this now, but that does not stand still, and we would need to keep investing in research and development, and it's reckoned we probably ought to be doubling our investment from the current $3 billion to $6 billion in this each year. Now, Wellcome and DFID are both in the top 10 funders globally of research and development for global health at the moment, and so this represents a big challenge for us. How are we going to respond to this challenge that is coming up here? But I'd say it goes further than that. It's not just for us. I think it's for all of you here if you're interested in global health. How are we going to rise to this challenge that we are, within a generation, able to eliminate these health inequalities? And that's really the challenge I want to leave with you this evening, other than to say that if you want more information, you can come and talk to either myself or my colleague Lara Bethke, who is here and is the main point of contact for this centre, or indeed, if you click through, you can find out lots of information on our website. Thank you very much.